I'm David Collier, and I'm a medical director at Kyverna, which is a relatively new biopharmaceutical company. And we'll talk a little bit about that. In fact, as you can see, we started in May 2018, and soon after we got from the NIH a CD19 CAR T cell, which I'm going to talk about, and a researcher in Germany named Schett put it into a patient with lupus who had a lot of difficulty with a lot of medicines, was going down the tubes, not doing well, gave the CAR T, and she has been in remission. He published a 6-month study in the New England Journal of Medicine, and then in Nature, a 1-year study, completely in total remission on no drugs. So that's the beginning of this. So let me go back here. In 1980, when I got into the scleroderma business and started a scleroderma clinic at the University of Colorado, we were, a group of us got together and did the D-penicillamine study, a study in about 1985-86, because D-penicillamine was kind of standard treatment, but no one ever really studied it very well. And in fact, I looked back on over 45 different drugs that had been used in scleroderma, and all the studies were just pure crap. And they were pure crap because they didn't understand the natural history of scleroderma at that time. So they took people with 20 years and 1 year, limited and diffuse, and they put them in 40 drugs. And Eric Bywaters came up with this statement that no drug has been shown completely worthless until tried in scleroderma. So at that time, patients would come in and said, you know, I've told I have this disease and there's no treatment. And I developed a 15-page handout that said, no, we have an approach. We have an approach to your esophagus. We have an approach to your Raynaud's. We have an approach to your kidney. But we don't have a cure for scleroderma. So since 1980s, we have a whole bunch of drugs that have been approved or looked at and look very well in scleroderma. And it started with the pulmonary hypertension drugs. The anti-endothelians and the prostacyclines showed a good effect in a disease that was relatively fatal. Severe pulmonary hypertension was fatal. In fact, the lung diseases are the organ that is going to kill scleroderma patients usually. It's the pulmonary hypertension, interstitial lung disease. And then, you know, we have these diffuse, and Dr. Richardson gave great talk about, you know, our approaches, what we have. But many of these drugs don't work in everyone or have a minimal effect. So scleroderma is a combination of a fibrotic, vascular, and immunologic disorder. So, I mean, it's fibrotic in your skin and your lungs. It's vascular in your lungs, pulmonary hypertension and Raynaud's. And renal disease is actually a vascular disease. And then it's an immunologic disorder. You make a plethora of autoantibodies, SCL70, anti-centromere, RNP3, a bunch of others, PM, SCL. But probably behind scleroderma, behind all the fibrosis and vascular issues, is this immune dysregulation. If we could reverse the immune dysregulation, we may be able to stop the whole process. You don't get fibrosis unless you have inflammation. It has to go through an inflammatory phase to get fibrosis. You don't get it. So if we could do something about, you know, stopping the immune process and revitalizing the immune process. So we've also got a lot more insight into B cells, and I'm going to show you some data on this. B cells were thought to be mainly precursors to plasma cells making antibodies. But B cells do a lot more than that. They are bags of cytokines that, when released, cause inflammation. They also have the ability to take in an antigen and present it to a T cell. And your T cell is kind of the conductor of an immune response, an adaptive immune response. And I'm going to talk a little more about this. So this is an anti-centromere. This is a fluorescinated antibody against an antibody, and this is your cell. These are, I think these are liver cells. And it shows that you make antibodies to your centromere. Your centromere causes the DNA to divide. So we make these autoantibodies. We don't know how they're involved in the disease. We have no real idea how these antibodies are involved in the disease. So CAR Ts were developed for cancers. And a CAR T, in its most simplest form, it's a chimeric antigen receptor on a T cell. So what we do is we take a receptor and put it on a T cell that is specific for a cell. Now let's say you have a cancer cell. Let's say you have a B cell lymphoma. In the past, we would give you chemotherapeutic agents that would kill the cell, but they'd also kill your gut cells and your hair cells and make you bald and get you diarrhea and a lot of other things. But if we could train a T cell to just kill that cancer cell, then we would save all your other cells from getting damaged, right? From chemotherapy. And that's the idea of a CAR T cell. A CAR T cell, chimeric antigen, is putting a specific receptor or antibody or whatever on a T cell, a killer T cell, and have that kill the cell. And so these were developed for oncology. And there is a commercial CD19 CAR T right now. It's called Yescarta. And it's for lymphomas, B-cell lymphomas, and B-cell leukemias. It exists. It's commercial. You can go to your doctor, and if you have this, you can be treated for it. So in the last 5 years, they've done this complete rethinking and said, autoimmune diseases, if we could reset the immune system with a CAR T, maybe we could get at the basis of treating an autoimmune disease. And that's what this is about. So CD19 is on the surface of antigen on B cells, and I'll show you a little bit about this. So what we do is we take, we get T cells from you, we train the T cell to attack B cells, and you have good B cells and you have bad B cells. And we know in Scleroderma that we have treated patients with Rituxan and we get decent results in interstitial lung disease and in skin changes. So we know that hitting B cells has an effect. And the idea is if we could wipe out all your B cells and just have your stem cells repopulate the B cells and get rid of all the autoimmune B cells, when we repopulate, would that reset your immune system so you'd essentially be in remission? We don't say cure, but we say remission. Reset your B cells. Reset your immune system. So the NIH developed a CD19 CAR T that they thought was safer than the ones out there, Yescarta and others that were out there. And let me tell you, there's like 5 or 6 companies that are doing the exact same thing Kyverna's doing, CD19 CAR Ts. But this was a fully human CAR T, CD19 CAR T. They treated 20 lymphoma patients. It worked, just like Yescarta works. And they said, we have a good CAR T. Now, one of the first steps is to get lymphocytes out. How do we do this? Well, we apherese you. We bring you in, and for a couple hours, your blood goes through a machine, spins it such that we can get the kind of buffy coat, the white cells out, And there are many white cells. As you can see, they're monocytes, eosinophils that give you hay fever and urticaria, but they're, in the past, treated parasites and worms. Basophils, neutrophils are your marines. They're your first line of defense against an infection. They are part of your eminent immune system. And then lymphocytes. And lymphocytes come in two basic varieties, T cells and B cells. So T cells have a number of varieties to them, and they are the conductors of your immune response. They are the ones that take an antigen and tell B cells to make antibodies and directly attack cells, bacteria or whatever, and kill off bacteria. Now, the importance of having your immune system attack something versus a chemical, it's like antibiotics. Antibiotics don't cure you of a bacterial infection. What they do is they kill off enough bacteria such that you can get an adaptive immune system. It takes about 2 to 3 weeks for a new bacteria to come in and your immune system to take it in, form a response to it, form an antibody to it, and start attacking it. And so antibiotics give you that 2 to 3 weeks where your adaptive immune system can then destroy all the bacteria. And this is the whole idea. If we can train your immune system to kill off all the bad cells that are attacking you, repopulate it with a normal B cells, then we, as I said, may get long-term remission. So when we get out the Buffy coat, we cell sort it and get a specific cell, the CD8 killer T cell out. And on B cells are cells that turn into plasma cells and make antibodies. But as I pointed out, they're also bags of cytokine, and they also process antigen and stimulate T cells. Right now, available are a number of antibodies to kill off B cells. Rituxan is one of them. And in multiple sclerosis, Ocrevus is a more specific B cell killer. And these are used to treat rheumatoid arthritis, to treat multiple sclerosis. The trouble is you have to infuse it about every 6 months. Every 6 months you have to infuse it. And the other problem with these antibodies is they don't get into your tissue. They don't get into the lymph system. They don't get into the interstitium. So you're killing off the B cells that are in your blood, essentially. So CD19 is even more, as you can see, it gets pro-B cells to plasmablasts. So it's a pan-B cell. We don't kill off your stem cells, though. So when we kill off all these B cells all over your body, they will be replenished by your stem cells. So a CAR T is this type of treatment, in summary here, that we take out your T cells, we take out the killer T cells, we put in a DNA construct with a lentivirus that has a promoter that will make the T cell make all these, and this is a CAR, and I'll show you a CAR in a second here. And so that's the binder, and it finds B cells, and it has a second message. You need a second message to kill off the B cell. So on this construct is something that binds B cells and a second messenger that will kill the B cell. So this is the construct. This was developed at NIH. It's fully human. It's got a binder to the B cell. It's got a hinged area, and it's got the second co-stim that'll cause it to kill off the B cell. And it's got a membrane binder to the cell itself. So the CD3 is in the membrane of the T cell. We got the co-stimulator, and we got the binder to the B cell. So this is kind of what we do here. We apheresis you. We then process the T cells such that, as you see, we'll get out the killer T cells. We'll train the T cell to put on its surface this CAR, chimeric antigen receptor. And then we infuse it back into the patient. And it kills off all the B cells. And then we wait, 90, 150 days. You'll be totally replenished with your B cells. And that's it. It's a one-step process. Now, in Scleroderma, we've had some decent, after a number of missteps, like irradiating the lungs, to do stem cell transplants. But as you can see, a stem cell transplant is far more difficult to do. We have to bring you in, give you terrible chemotherapy, then radiation, then give you back your stem cells. You're in the hospital for a long time. As I said, they did some there were two studies, the U-STAR study and DAM-FIRST study in the United States, and had some moderate success when they didn't have complications of doing the stem cell transplant. So this is kind of between getting your chemotherapy and a total stem cell transplant. It's a easier process to do than hitting your whole immune system. So there are a couple of problems with this, and they usually occur within the first 2 to 4 weeks. And that is cytokine release syndrome. And cytokines are chemicals that cause inflammation. So if you get a viral infection, you have no idea you have a viral infection until your body responds to it. What gives you fever? It's your own cytokines. What gives you inflammation? It's your own cytokines. HIV is a great example of that. HIV knocks out T cells. So people who have AIDS don't know they have AIDS until they get an infection because their body cannot respond to that virus. It is the response to the virus that we get all our symptoms from. So you can get cytokine release syndrome, and this is mostly seen in oncology. Why? Because if you're knocking out a whole bunch of B cells, you release a whole bunch of cytokines because there's all these tumor in you. But if you're knocking out your own B cells, it's not that much process. And in fact, we've treated 54 people so far with our CAR T with various autoimmune diseases. We're looking at 8 different autoimmune diseases. And we've never had a stage 3 or stage 4 CRS, cytokine release syndrome. We've had a couple of 1 and 2s, and it's treatable. And you know what it's treatable with? It's treatable with Actimera. What's Actimera? Actimera is tocilizumab, a drug that's used in systemic sclerosis. It's an anti-IL-6. It's a very potent anti-inflammatory agent. So we can treat CRS. It's not like, you're going to die from it or anything. The other thing is ICANS, immune effector cell-associated neurotoxicity. So and we think this is also involved with the cytokine release, that you can get these neurologic problems. Anything from headache, fever, nausea, body aches, high blood pressure. They can be severe and serious that they've seen in oncology. No one has seen these in autoimmune diseases, though. So we've been pretty good at that. And we think that our construct is safer than a commercially available one. So I wish I could give you data on systemic sclerosis. Our first of 6 patients we're treating was infused last week. So our first patient that we're looking at in systemic sclerosis, but we've done multiple sclerosis, myasthenia gravis, lupus, whatever, and it's looking very good, and we're not having a lot of side effects from this at all. This is one of our first patients, a myasthenia gravis patient. She was on a lot of immunosuppressive agents, 1 shot of CAR T. She's been disease-free, no serious events, no background immunosuppressant corticosteroids. Her B cells were repopulated in 132 days. She is still disease-free. Back in service here. So we are very encouraged by this. Who are we looking at? Scleroderma means thickened skin, and there is a localized form, morphea, that's just patches on your skin, usually in older people, and linear scleroderma, which can be devastating. This is usually seen in young people, and is just a fibrosis, young women down their legs. At its worst, it's coupe de sabre. It can be in your face, and the problem is it causes bone growth problems. So you can have a very deformed face or a very deformed leg from it. But there's no systemic issues with morphea or linear scleroderma. Where the systemic issues are limited scleroderma and diffuse. And scleroderma is this huge continuum. There are people probably walking around with 20 years of scleroderma and don't know it. What they have is sclerodactyly, reflux, Raynaud's, maybe some telangiectasias, and that's it. That's it. They've never been diagnosed. That's a limited. And then you have other patients who, in 9 months, can fibrose their whole body, and that's a diffuse. And that's what we're interested in. We're interested in these patients who are rapidly progressive because the diffuse patients are the ones that get mostly in trouble with interstitial lung disease. And they're the ones that are mostly at risk for serious illness. So this is a diffuse patient, classic, mouse cob face, telangiectasias, acroosteolysis, diffuse skin fibrosis. And this is interstitial lung disease. You heard her talk about that. And this is one of the things that can kill you. Pulmonary hypertension and interstitial lung disease can kill you. You don't die from thickened skin. You don't die from Raynaud's. But you can die from pulmonary hypertension and interstitial lung disease. So that's what we're interested in, because we know Rituxan has helped patients with interstitial lung disease and has helped their skin. So we want patients less than 6 years of disease. Why? Because the natural history of diffuse scleroderma is to fibrose for 5 years and then to start going into atrophic phases. Although Denton in Europe always shows this slide where there are kind of 3 courses of atrophic phase, where your skin, the thickness goes away, in fact gets thin. It can be fast, it can be slow, and then there's the no changers. But in general, we want people that we can measure a decrease in their skin progression. We want people that are progressing in their skin and have diffuse disease, which is defined as proximal to your elbows or knees, over the chest, whatever, excluding your face. That's common in limiteds. So, and we want bad interstitial lung disease. So you fail 2 medications, you have a forced, these are PFTs, measures vital capacity and diffusing capacity of less than 80%, evidence that you're declining in these, that you're getting worse. Because as he pointed out, there's a lot of patients with ILD and they just don't progress. We don't want that. We want people that are progressing in their ILD, because how are we going to show that our intervention is working? We have to show that it's stopping the progression and making them much better. The nice thing about this study is we don't care what you're on. You can be on anything and go in this study. And you can stay on it. You stay on it till you get apheresed, and then you can go back to it until 2 weeks before our infusion of the CAR T. So there's no exclusion of any drug that you're on, other than being on an experimental drug. So, but you can't have significant pulmonary hypertension, cardiac disease, gastric antrovascular ectasia, the watermelon stomach, renal crisis, or active infections, and no overlaps. We don't want PMSCLs, we don't want polymyositis overlaps or lupus overlaps, whatever. So we treated the first infusion October 14th, so I can't tell you how we're doing, but we're very excited about this. So this is a therapy that is already approved for oncology patients, and we are waiting with bated breath to see the results we've seen in lupus and the results we've seen in myasthenia gravis and the results we've seen in multiple sclerosis, will we see those year out, no evidence of any disease whatsoever off all drugs? That's our goal. And the NIH views this as very experimental and very aggressive. So they want like follow-up for 15 years once you get in this study. But thinking about it, if this works, you get one treatment. You don't have to be on MMF, mycophenolate, Cellcept, for years. You don't have to be on Cytoxan for a year and then go to mycophenolate, whatever. You get one treatment. That's it. So this is showing the process and why they consider it aggressive. We screen you, make sure you meet all our criteria. Then we apheresis you, and then we send it off to get cell sorted and put the construct in, the CAR T in. We use a lentivirus. It puts a DNA in with a promoter area, and that causes your cell to put it on your surface. Then the most aggressive thing is the preparation for treatment. This is an oncologic protocol that everyone's using. All the companies use this. And we give you 3 days of Cytoxan and 3 days of fludarabine to knock out all your lymphocytes. Why are we doing that? Because the oncology studies have shown that the CAR T will take and be very effective if we get all your other lymphocytes out of the way. So we really knock out most of your lymphocytes for 3 days. We bring you into the hospital. We infuse this drug and watch you for 10 days. And then for the next 18 days, you have to be within an hour of the hospital. After that, we don't see side effects. That's it. If we see CRS, we can give you anti-IL-6. If we see ICANS, we can give you anti-IL-6 and follow you. And that's it. Follow-up period, as I said, the NIH would like, FDA would like us to follow you up for 15 years. So we'll try to follow you up for 15 years after giving you this. So there's the apheresis, collect T cells, preparation for treatment. We lymphodeplete you. Then we infuse the CAR T. We watch you for 10 days and follow-up period. So in summary here, these are modified T cells to kind of reset your immune system. Data we've seen so far looks very good. We haven't seen a lot of side effects, and we've seen some great efficacy, but it's still very early, and I can't give you specific scleroderma data. But as I said, there are like 5 other companies that are doing this. The big one's Bristol Myers Squibb. So, any questions? As I said, I love talking to scleroderma patients. I used to do it all the time because I get a lot of questions and people seem interested. Yes?
Sure. You mentioned there are good and bad B cells. I've heard a lot about the B bad cells. What are the good B cells?
Well, you have B cells that are fighting off strep and, COVID and whatever else, making antibodies. So those are good B cells that respond to infections.
Is there a percentage of good B cells versus bad B cells?
I don't know that percentage, actually, but the vast majority are probably good.
Hi.
Oh.
So if Rituxan can kill off B cells, and then you don't have any for a while until they come back, why wouldn't they come back as good stem cells, even if it's just for a short period of time?
So Rituxan only kills B cells in your blood. It doesn't kill B cells in your lymph or your muscle or your brain, but the CAR T does. The lymphocytes can move around any place, but antibodies are kind of stuck in your blood. So it doesn't wipe out all your B cells. It just wipes out the ones in the blood. And I specifically asked that to a neurologist, and one of my friends has multiple sclerosis and is getting Ocrevus. and they have no B cells in their blood, but they're getting Ocrevus every 6 months. And she said, well, they're sitting in his brain. We can't get to them. So we're giving him, to prevent more B cells, to prevent them getting in the brain.
Over here.
Yeah.
Yeah, I have two questions. The first one is you talked about B cells and the autoantibodies for scleroderma. So there are patients, me included, for example, that have all the scleroderma autoantibodies negative.
Right, and that's
So,
fine.
and this therapy would be independent of that, or do you need to see evidence of scleroderma?
That's a really good question, and we're just at the beginning of this. But at EULAR, which was a big European League Against Rheumatism meeting, a abstract on the effectiveness of Rituxan showed that there are two groups of scleroderma patients. There are B predominant and B non-predominant. And this study compared tocilizumab, Actimera, with Rituxan and found Rituxan was much better than tocilizumab if you were B predominant. If you were B non-predominant, tocilizumab was a little better than Rituxan.
And the B non-predominant is the people who do not have autoantibodies?
Well, we don't know that.
They don't know that
They
yet.
looked at
Okay.
B cells in your skin, the
All right.
amount of B cells in your skin. It was a direct B cell count. So in the future, we may be able to be more precise and say, you are a CAR T B cell person, but you may not be as responsive.
Right, but at the moment when you select your sample of patients...
We take everybody. We take
can have
everybody who meets our criteria, yeah.
Okay, so let's go back to the criteria instead. The criteria are a little bit stringent because it's really looking at people with recent diagnosis but that do not respond to therapies. And is that not biasing a little bit your sample because
This is
you're
what
really the worst of the worst?
Yeah, no, I mean, as someone who's developed it, in general, we know that the earlier you treat and the less you've been treated, the more likely you're going to respond to our drug. This is true in RA, lupus, whatever.
Right.
If you failed 3 drugs in RA, the 4th drug, you're probably going to fail, okay?
Okay.
That's just the way it is. But the FDA considers our therapy so invasive that
see.
they only want us to look at failures, people who
Who
aren't
really-
responding, who aren't doing well, or whatever. My vision, 20 years hence, is this may be the first therapy you go to.
No, exactly, because somebody who responds well and can have a quality of life which is the same as a normal
Exactly.
person
But-
would be the ideal candidate for that, right?
But that's not the FDA. The FDA specifically wants us to look at the worst patients who haven't responded
Yeah.
because it's so invasive.
And do you think there will be ever a possibility of increasing that
We
threshold?
are, the first thing we're trying to do is, the FDA told us they had to fail 2 drugs with ILD. We want them only to fail 1. We actually have put an amendment into our protocol to do that in front of the FDA. But the FDA calls the shot for us to get it approved.
All right, thank you.
Thank you so much,
Okay.
Dr.